Hello, welcome back as we approach National Breast Cancer Awareness Month in October. Today, I'm not talking about COVID-19. Today, I'm going to talk about the best of breast. I'm going to talk about the best breast cancer risk reduction calculators that are out there. A lot of you haven't heard about this stuff. This is more than do your annual mammogram, ladies. Men, stay tuned, because if there's a lady in your life, you want to help keep her safe. So stay tuned. We're going to talk best of breast risk cancer awareness calculations. So hello, I'm Dr. Oscar Hernandez, board-certified internist and practicing pediatrician. You know that we've been talking about all these COVID topics lately, and we're going to still be talking about important COVID topics. But just a few days from now, in early October, we start National Breast Cancer Awareness Month. So we always hear the same drumbeat and hoofbeats about do your mammograms. Sometimes we talk about breast self-examination, what we call BSEs. Breast self-examinations, by the way, ladies, they're not a bad idea, especially if you do them in the shower with soapy hands and stuff, and you do them once a month. Don't do them right before your periods, because you know that some women get some swelling of the breast tissues and they think they have a lump. Do them after your periods. But the breast self-examinations haven't been really that tremendously useful when we really look at them and look at mortality reduction. But hey, if you want to do them, I think that's a great idea. Why not? I've seen through many years of practicing medicine women who come and they point out the nodule that maybe there was no mammographic evidence for on the last mammogram. So not a bad idea. But we have better things that we do that have a greater yield in terms of knowing how to avoid mortality and morbidity from breast cancer in women. Of course, we talk about mammograms. Please, ladies, do your mammograms. I'm not against mammograms, and by the way, there are other modalities that have to do with thermal imaging and so on. Those are not the same as a mammogram. And remember that an ultrasound is not a replacement for a mammogram, although it can certainly be an adjunct or an additional study. But today we're not really talking about mammograms, we're not talking about breast self-examinations. I'm going to review an article from the Mayo Clinic proceedings that came out in June. Oh yes, stuck in the past in June, when all we heard about was COVID. Well, there's a lot more to life than COVID, and again, we're going to stick to COVID, but we're going to talk about this today. So, as medicine develops, we're getting more into what we call personalized medicine. The whole breast cancer screening panorama is not a one-size-fits-all. Yes, everybody needs mammography, especially after the age of 50. It is done in women who have no significant other additional risk factors for breast cancer, and they are generally recommended by the National Task Force for Preventive Health every 2 years. Other organizations recommend yearly mammograms. It depends on who you listen to. I follow the National Task Force on Preventive Health recommendations, but if a woman says, hey, I want that yearly mammogram instead of every 2 years, I go ahead and I do it anyway. We generally start these at the age of 50. Now, in the old days, we did a baseline mammogram at 35, and then we started mammography at the age of 40. There are women who should get mammography starting at the age of 40, but that's not by and large everyone, and that's not what I recommend. So again, one size does not fit all. Now, what are the criteria that we use to help determine when women fall outside this norm of, just rubber stamping every 2 or every 1 year mammogram, whatever recommendations you're following, starting at the age of 50? Well, I'm glad you asked that, because we actually have some answers for that. They're not perfect answers. So this review that came out in the Mayo Clinic proceedings talks to us as physicians, and I'm going to pass on this knowledge to you, about incremental steps that we need to do in terms of performing personalized medicine when it comes to breast cancer for our patients. And the first step is to determine family history. And then we talk about personal history. And then we use risk prediction calculators. And then based on this panorama of information, we go ahead and we say, this is what I recommend for you in terms of breast cancer screening. So let's start with step 1. We look at family history. There's a little questionnaire that all of you can dig up. if you want to. It's called the 7-question family history screening, or the B-RST questionnaire. And what it's looking for is a family history for women who have had a first-degree relative, especially if they were less than the age of 50. And we're looking to see if these relatives had breast cancer. If so, it puts you at an increased risk. If you have personally had a breast biopsy showing ductal carcinoma in situ, which is a very self-contained carcinoma, or DCIS, ductal carcinoma in situ, or even LCIS, lobular carcinoma in situ, these are all higher risk conditions, and the calculators do not work on those types of women. If you've already had breast cancer, then this is not a discussion for you. You are in the highest risk group of women who may have a repeat breast cancer. So that's not the group we're talking about. Also, there is a history of ovarian cancer in your family or male breast cancer. That puts you as a woman in a higher risk category. Once we've looked at your family history, and I do these BRST questionnaires on all women when they first come into the office. Some of you are existing patients. You have not filled out this calculation because it's something that we've recently started. Please, if our staff doesn't give you a screening tool, I want to make sure that you ask for it. The next thing we do is we look at your family history. Are there any hormonal factors? Are you in a group that simply by ethnicity falls into a high risk of breast cancer? And if you have had dense breasts, we look at this also in our assessment. Once we have some baseline information, then we whip out our calculators. And you can do some of these calculations yourself online. There are 3 main calculators that I use in my practice. I'm going to name them. I'm going to talk a little bit about their application. So the oldest one that is in existence happens to be in my drawer. If you can see this on camera, it has the name of a medication on it, Novaldex. This used to be the trade name of a generic medicine called tamoxifen. You're actually looking at a vintage piece of medical equipment. I got this, it was given to me by a drug rep back when drug reps could give out stuff. Many years ago, probably 25 years ago, I got this calculator. And for a long time, this was the only calculator that was available. Now, this is an actual calculator, but you can go online and do these things. You can get the same thing online. You don't actually have to physically have a calculator. But I still keep it in my desk because it still works. I've had to change the batteries a couple of times. But the first risk calculator that we came up with was that little device called the Gail calculator, G-A-I-L. We don't really use the Gail calculator a lot now unless we are trying to determine if a woman should be on medications to help decrease their risk of breast cancer. Which brings me to the question, why do we use risk calculators? Why do we even do a risk assessment in patients? Well, I told you that we were developing more and more the concept of personalized medicine. And based on the risk that these calculators give us, there are a number of things that we can do. We can do increased surveillance. We can talk about that in a moment. We can prescribe medications to decrease the risk of breast cancer. We can send you for genetic testing if that is appropriate. And in certain situations, we can even send you or recommend or ask you to consider bilateral mastectomies. Angelina Jolie did this because she was in a high-risk group, and many years ago she had not only bilateral oophorectomy, which is removal of the ovaries, but bilateral mastectomies. It's not for everybody, but I'm just telling you what she did. I don't know the specifics of her medical situation or calculations. So there's the Gail calculator. Unless we're talking to you about giving you medicines to decrease the risk, it's not the number one calculator. The next thing we do is consider using the Breast Cancer Surveillance Consortium calculator. Now, maybe we can put this on the screen. You can go to this website and do your own calculation to see if you are in a high-risk group. If your doctor doesn't do it, and I'm not your doctor, or we messed up when we didn't do it for you, you can do this yourself. Hey, what's a good time to do it? October's coming up. National Breast Cancer Awareness Month, right? So This is why we're doing this program, because we want you to increase your risk, your understanding of breast cancer awareness. If you go to that site, you can click through the questions. And we love this calculator because this calculator is the only one that is commonly used that takes into account the issue of breast density. Breast density has been all the rage for the past couple of years. And remember, breast density comes in 4 different flavors: A, B, C, and D, according to what we call the BI-RAD classification system. So breast density A means you have normal breast density. Breast density B means that you have some more density to your breast. C and D confer a higher risk of breast cancer. But it's not just as clean as knowing whether you're C or D. Plug that information into that calculator, the Breast Cancer Surveillance Consortium calculator, as well as some family history for first-degree relatives. That means mothers, sisters, aunts do not count. Grandmothers do not count because they're not what we call first-degree relatives. And then it'll give you what your risk in 5 years and for lifetime is for developing breast cancer. Now, if you have a bigger family history, maybe you have aunts, maybe you have grandmothers, maybe you have more distant relatives and male relatives that had breast cancer, then we use a different calculator, the Tyrer-Cuzick version 8 breast cancer calculator. We can also put that down. There's a website where you can find this calculator. And if you have a significant family history of second-degree relatives, that means those more distant people who had it, that's the calculator to use for you. All of these calculators, whether it's the Gale model, whether it's Tyrer-Cuzick, whether it's the Breast Cancer Consortium calculator, will then give you what your 5-year and lifetime risk of breast cancer is going to be. Here's the magic number to know. If you have greater than 20% lifetime risk of having breast cancer, then we should whip out all the guns, press all the nuclear options, and protect you as best we can. And one of the things that is easy for me to recommend, because almost every professional organization and recommendation agrees that if you are in that group who has more than a 20% lifetime risk of breast cancer, you should be getting aggressive surveillance. That means that we're going to be looking at your MRI and your mammogram every year. How do I generally do these tests? I order a mammogram, 6 months later an MRI of the breast, 6 months later a mammogram, 6 months later an MRI, and I do this sequentially for many, many years. This is aggressive, this is expensive, this is inconvenient, and this can be life-saving. So that's what we do with folks who have more than 20% risk. Also, if you are in a group that is postmenopausal, I often recommend something called raloxifene, Evista. Raloxifene is the cousin of tamoxifen, which was the name on that breast cancer calculator, Novaldex. We like Evista, raloxifene, better because there is no significant increased risk of uterine cancer, which we do see with tamoxifen. So we protect you against one thing, and then we predispose you to something else, and that's bad juju. It doesn't happen with Evista. By the way, if you've had clots in your legs or a history of strokes, it's not a medicine that I would probably recommend. We may also think about sending you for genetic testing, right? If your breast cancer risk calculator is high, we do that. Even if it's not high, but you have family members, first-degree members, a mother or a sister who has had breast cancer, I almost always recommend genetic testing and genetic counseling. By the way, genetic testing is more than just send away for a test that you might get in the mail or demand that you get a test. The interpretation of these tests can be tricky. Just because you have a positive gene that predisposes you to breast cancer doesn't mean that you won't get it. And by the way, most women who get breast cancer do not have genetic susceptibility. So you need to know how to interpret that. By the way, if you're looking for a simple test, it costs about $200 that you can order online, and it'll give you reliable genetic information about breast cancer and a number of other things. Go to the Color Test. Color Test. I think it's .com. If you have any questions, can't find it, info@metromedfl.com. Send me a message. I'll find it for you, because right now I'm just saying it off the top of my head. If you have less than a 15% chance lifetime of developing breast cancer, then you probably don't need to do anything special other than to follow those National Task Force on Preventive Health or whatever other professional organization you're following, which means that after 50 you're getting a 2-year mammogram, at least until the age of 75. We continue beyond 75 if we think that a woman's chance of living another 10 years is good. That's guesswork in many cases. But anyway, if we're older than 75, we still do mammography in many women based on what we think their life expectancy is going to be. The killer comes with those women who are between this 15% and 20%. What do we do with these ladies? Well, almost every recommendation says that we shouldn't be doing MRI exams on you. Almost every recommendation says that your breast density is not a good reason to go do ultrasounds on follow-ups. Almost every recommendation says that we do not do genetic testing on you, and almost every recommendation says that we don't go doing willy-nilly biopsies or ever recommending bilateral mastectomies or anything else, just based on that risk profile. Now, if you have a biopsy that shows something, that's a different thing. But remember, if you have abnormal findings on a breast biopsy, none of these calculators generally apply to you. All right, so I think that's all I'm going to say about breast cancer risk reduction calculators. Those are the 3 best for breast that I recommend for our listeners and for our patients. Remember, if you're not one of my patients, talk to your doctor. By the way, this is a copy of the article, so it's from Proceedings of the Mayo Clinic. It's a very respectable journal. We live in tough times. I've said it many times, and many times I've asked you to dig deep within and find the roots of your faith, because deep within is not where we find our greatest strength. It's from up above. But sometimes we have to touch base with our faith before we raise our mind and our hands and our hearts to up above and ask for help. And sometimes we don't realize the protection and love that God has for us. So today I'm going to reflect on a scripture that the Apostle Paul wrote to the church in Corinth. Corinth was a place where Paul never actually went. It was founded as an early church, and people can still go to Corinth and see the Christian churches in Corinth. It was a church in Greece, and he wrote them letters that would encourage them and exhort them. And in his first letter to these Corinthian Christians, many of whom were Jews that had exiled out of Rome and fled to Greece because they had changed to the Christian faith and they were persecuted by many of the early Roman emperors. Here's what he wrote to those people. Some of them were doing very well. Some of them were struggling to move forward. Like many of the folks in our area here in Miami, most of them were refugees, right? They had come fleeing from something else. And this is what he wrote when he tried to exhort them. He mentions a scripture out of the Old Testament, and he says, "As it is written, eye has not seen, ear has not heard, neither have entered into the heart of man the things that God has prepared for those who love him." This is a promise for believers. This is not a promise for those who are agnostic, or we don't know, or, pound their hand on the table and say there is no such thing as a God in heaven. I am a strong believer in the Christian faith. This is what Paul writes to those who are his followers. Take heart. If you're a person of faith, bank on your faith. If you're not a person of faith, make this a time of reflection, because the world is changing all around us, but there is something that doesn't change, and that's the Word of God. If you like this video, give us a thumbs up. If you don't, send us a message. We want to do better for you. We talk about a lot of other stuff on these programs. We've been talking mostly about COVID. Here's a change today. Last time I changed the topic and talked about fasting programs, almost nobody watched. So, folks, if you want to hear about something other than COVID, send this to your friends, to your relatives, have them sign up. We're going to be here for you all the time. On screen, in person, we've never closed our office. We're always here for you. Thanks for listening. We'll be back soon.